Welcome to our first webinar for South East London Cancer Alliance Primary Care Webinar Series. So today's webinar will be on screening and the 3 screening programs. So before I introduce our speakers, I'm just going to go through some housekeeping rules and also evaluation forms and certificates. So everyone is muted and all of your cameras are off by default. If you have any questions, at the bottom of the window, you'll have a Q&A button. So please send in any questions there, and my colleague Bav will be looking at them. Also, if there's any technical issues, please let us know via the Q&A button as well. If you need to discuss anything further with regards to your question, then please let us know in the question that you ask us. And finally, the presentation will be recorded. The reason being for that is I'm sure that some colleagues can't attend and they'd like to. So what we'll do is we'll host this on our website, and colleagues can then relook at this at a later date. So with regards to certificate of attendance, we ask that you complete and the evaluation form. The evaluation form will be sent to you via a link via Eventbrite. Once you complete that, a certificate will be sent to you, and you can use that certificate to show in evidence for supporting and completing the early diagnosis DES. So these are speakers, and this is the running time for today's webinar. So we'll first kick off with bowel, and then breast, and then cervical. So David and myself are from the Cancer Alliance. So we'll be going and giving you an overview of bowel. Breast, we're joined by Keshthra, who's the director from our South East London breast screening service. And so she'll be discussing breast and also the what's happened to breast services because of COVID, and also plans for recovery. And then cervical will be led by our GP lead, Nicola. So she's our GP lead in Southwark. And then we're also joined by some panelists who will be able to answer any questions that we can't. So we've got Caitlin from CR UK. She's a CR UK facilitator. We will be joined by Lillian and Emily, who are lead SSPs at the Lewisham Bowel Screening Service. Sarah Robinson and Alison Ferdinand, who is from NHS England and Improvement, and she is our commissioning manager. So we will now kick off with bowel screening. So this is just an overview slide, of bowel cancer screening program. So I'm sure a lot of you are aware of this already, but I will just run through this pathway. So patients who turn 60 will be invited to carry out FIT screening. So what will happen is they will be sent an invitation to invite them to screening, and then they will then be sent a FIT through the post. And a FIT is a kit to determine whether there is any blood in the stool. It is a really sensitive test. The sensitivity level is set at 120. What will happen then is if patients have a FIT positive, they will then be sent for and be offered a colonoscopy, and that will be taking place at one of our screening centres in South East London. So we have one in Lewisham and we also have one at King's. Invitations for screening are based on the information that GP practices hold. So obviously it's really important to make sure that names and addresses for bowel screening are up to date, so that the invitations that are sent to patients get sent to the correct addresses. You'll also see there is a test called the bowel scope screening. So this is inviting patients to attend a one-off flexi-sig. that the invitation gets sent around their 55th birthday. At the moment, that is paused indefinitely. That is because of COVID and the effect of COVID. David will speak more about that in the next slides and what the plans are for those patients. But we thought it was really important to highlight those two different screening invitations for people for bowel screening. So this slide is highlighting the differences of fit in screening and also fit for high-risk symptomatic patients. So you'll see some similarities, both for symptomatic and for screening. We do ask patients to complete a fit. It is the OC sensor fit kit, which I'm sure you're all aware of what it looks like, but there are some differences in how patients receive it. So for screening, the positivity threshold is set at 120. For patients presenting to their GP, the positivity threshold is set at 10, so it's much more sensitive. Patients receive the fit test for screening via the post, whereas in symptomatic, they are given it by their GP in the GP practice. The kit is returned via the post box for screening. For symptomatic, patients are asked to take it back to their GP practice. The go live date for screening for fit, the move from FOBT to the fit kit, was in June 2019, and the move to high risk fit in symptomatic patients was in April 2020. So this was during COVID. There were a lot of communications around that. And patient information leaflets on how to carry out a fit. For screening, it's sent with the kit, and for symptomatic, it's given by the GP, and those patient information leaflets are available on TQuest and also via the HLP website. So that's a little bit of background there. I'm going to pass over to David, who will be able to provide further information.
Hi everyone. So this is just a very quick slide on bowel screening in South East London. So on the left, you can see a graph of breakdown by CCG. And you can see there is quite a lot of variation in the uptake for bowel screening across the sector. There are some CCGs where it's pretty comparable with England and in some cases better than London. And there are some where it's worse or uptake isn't as high as it is elsewhere in the country. But having said that, even in CCGs where uptake is high, there's still a lot of variation. And you can see that on the right-hand side. I've obviously anonymized this data, but you can see there's a lot of green, but also pockets of red, where individual GP practices, their uptake is not as high as elsewhere. So just because your CCG is performing highly on this particular metric doesn't necessarily mean that there isn't a problem. And so that's more about trying to, you're at your individual practice level, if that's where you're dialing in from, understand what your uptake is, and I'll come on, there's a slide later about how you can potentially support uptake in patients participating in the screening program. So next slide. So Zara mentioned about some of the impacts of COVID, and this, as most of you will have probably seen from the previous slide, one of the biggest bottlenecks in screening at the moment for bowel is the availability of colonoscopy. So during COVID, all but emergency endoscopy was stopped, and obviously that impacted bowel screening. So bowel screening was stopped because it's not, there were no colonoscopies happening, and there were patients flowing through this pathway all the time during that period, and they were all paused at different points. And so when we talk about recovery, at the moment there is a very fast-paced and intense recovery program around endoscopy and also bowel screening. The two are aligned. Obviously, the increase in endoscopy capacity directly relates to the ability for screening to return. So the screening program, the bowel screening program, has prioritized sets of patients based on the return of services. And the First priority is obviously all those who have a positive FIT result and are due to have a screening colonoscopy. Luckily, that backlog is cleared in South East London, so we are more or less completely up to date on those patients. So now we have the next backlog, which is what we'll call tier 2, or the yellow in the middle of the triangle there. So these are patients who are invited to the screening program but have not yet been screened. So their FIT kit's not been sent, or it's not been returned, or they're pending an appointment with their SSP. And there is lots of modelling and ongoing work to try and clear this backlog, but the anticipated clear date is by October or November this year. But obviously one of the key constraints on that is colonoscopy capacity. And then the last one is around people who were delayed in invitation. So people who have, say, fallen into their 2-year interval or have recently turned 60, they've not received an invitation during the COVID period in order to stem the flow into endoscopy. So that's obviously a much, much bigger number. And we're trying that's the sort of tier 3 priority to try and clear. And the balance with that is around endoscopy capacity, but also keeping pace with all those people who will fall into that category over the next sort of few months and weeks. So the anticipated clearance is around spring, summer of 2021, but that's obviously whilst we're also keeping pace with those who are due now, so we'll be completely up to date by then. So as I mentioned, the biggest constraint around this is endoscopy capacity. So if we go to the next slide, as I've mentioned, there is a huge amount of work going into recovering endoscopy services in South East London. This slide represents the plan for our region. The dates are basically between July and September, but this actually is October now, to be honest. And it's called a waterfall chart, but effectively what it does is it plots out all the additional activity that we are planning to realise through various work streams. And they range from infection and prevention control changes, so the recent downgrading of lower GI endoscopy as a non-aerosol generating procedure means that different IPC protocols can be followed, less PPE, for example. And extended hours there, you can see, has a huge impact, and that's about moving to 7-day working, running all rooms, and that there's a lot of potential there because some of our rooms are yet to open in South East London, and a lot of that relates to different ways of maintaining clean pathways and ensuring we keep patients safe. And then there are other work streams which I won't go into in detail, but the one to mention, which you can see there, is bowel scope screening cessation, which is the BSS cessation. So as we've mentioned, that's the one-off flexi-sig at 55 years old. That has been paused indefinitely. No one has said that it's been completely cancelled, but certainly no one is talking about returning it anytime soon, predominantly because the capacity that would be needed, the capacity in endoscopy that would be needed to return that service obviously should be prioritised for the FIT positive colonoscopy patients, for which there's a really strong evidence base around the predictive power of possible bowel cancer in those patients. It's about 8% if you have a FIT positive within the bowel screening program. It's about an 8% chance you'll be diagnosed with bowel cancer. So just the latest on that. So you can see on the left-hand side, previous activity for endoscopy was around 3,500. And in the last month, we've performed 3,227. So we're a long way down this plan, but a long way to go, because just returning to previous levels isn't enough. We need to provide surge capacity to clear backlogs and reduce waiting lists. So yes, a long way to go, but there is a plan. So in terms of how you can support, if you have a patient who is falling due onto the screening program and they receive the FIT kit, please encourage them to take part. It's really important that patients continue to take part in screening and that we capture cancers early. I don't want you to be put off by any issues we see around endoscopy capacity. Bowel screening is a complete priority within that program, so please encourage patients to take part. If they have any questions, there's a bowel screening helpline service, which there's a number there for you, but it's widely available online and through lots of patient information leaflets. And if they then have an appointment with their local screening service, again, please encourage them to attend. And if they have any questions about that, there is a helpline that they can contact the generic helpline or their screening service directly. And then we understand that obviously patients will probably have a lot of questions about what it's going to be like coming into hospital, and especially if they're coming in for an endoscopy at the moment. So there is a video that's been produced by our colleagues in the West London Alliance, who have kindly shared that across London. It's available on YouTube. It's probably all over Twitter by now, but there's a link in these slides which you can use. It's aimed at patients, but it's obviously probably really useful for yourselves to watch as well. And if you have any questions or ideas about how you can further support, please do put them in the Q&A.
Thank you. So any questions? This is when our technical abilities are showcased here.
So there are a couple pending for you, Zara, that you should be able to see.
I think I can, yeah. So number one, who sends the scope screening letters, and are GPs involved? Is the invitation automatic or by request? That's a good question. So what happens is they are generated by the Bowel Screening Hub. They use the information available so the Bowel Screening Hub uses the information that is held on GP practices, so details, addresses. So obviously the invitations were paused during COVID. These have started back up again, as David had said. So they are sent out from the Bowel Screening Hub. We've got a hub in London, and those invitations, that's how they're generated.
And GPs are involved. You get a copy of all of those letters.
Can I just add that if you have missed your 55 invitation, you are entitled to get in touch with them and request a screen up to the age of 60, after which point you go into the normal screening programme.
Thank you, Nicola.
Is that so I know, Caitlin, you put your hand up to answer that, but the breakdown of fingertips data by PCN is pending. So that will be available on fingertips, but Caitlin.
Yeah, thank you, David. I was just going to say the exact same thing, that there is provisional fingertips data for PCNs now available on PHE's website, which is really helpful for those conversations about the DES. And if you'd like more information about how to navigate fingertips, how to understand your data, you can contact the facilitator program. We'd be happy to help with that.
And what we'll do is at the end of the presentation and the slides, the FAQ that will be sent out with all the answers on, we'll put the details to the facilitator program, so the generic email address. So you guys have got the contact details for all of us if you've got any further questions. There's lots of questions that are being generated. I think what we should do is answer these offline and send them to you guys, if that's okay with you, because I know we're tight on time. So I'm going to close this, and I'm now going to pass on to Keshthra, who will be taking us through breast screening. So if I can work great.
Perfect. So thank you very much for the opportunity to come, because this is really important. And I think that, having heard the first talk, there's clearly some themes that are going to be common to all of us, which is going to be a good thing. So I'm Keshthra Satchithananda, and I'm the Director of Breast Screening for the South East London Breast Screening Programme, and we have Jerry Kirby, our Programme Manager, on the call as well. So if we can go to the first slide. What I aim to do is, it's a short talk because I'd much rather answer questions and to sort of take some guidance. But what I'd like to do is review what the screening process at the moment is as far as invitations are concerned, highlight what's going to change, and there are some big changes that are going to come just for an interim short interval afterwards to enable us to recover, the risks of these new changes, and also the ask which we have for colleagues in primary care. If we could go to the next slide. So currently we have a screening program that invites ladies for mammograms every 3 years. Our core contract is to screen ladies between 50 and 70. In the last 10 years or so, there has also been an age extension trial trying to see if having a mammogram between the 47 and 74 has also been running, but since COVID that has been ceased. That has not been a waste of a trial. In fact, there are over 5 million women in that trial, and they will publish their findings up till now. So hopefully that will help us or inform us as far as policy is concerned going forward. Once we've stopped screening after 70 and 11 months, then ladies are encouraged to self-refer themselves every 3 years. That's the current process. We have a central admin hub, very much the same model as bowel screening. The admin hub is based at the Royal Free Hospital, and on collegiate kind of planning with the South East London service, appointments are sent to clients via the post. Then before the first timed appointment at a location close to home, they will get a text reminder at day 7 before the appointment and day 1 or 2 before the appointment. If they attend for screening, of course, they'll get read and their results will be communicated to them, or any further tests performed. If they don't attend that first appointment, then a second timed appointment at a location is sent automatically. Again, they'll get text reminders before that, and then we hope that they will come. And actually, we do get quite a reasonable uptake and an increase in about 20% of those second time appointments. If they haven't come within 6 months of that first appointment being sent, the episode, as far as screening is concerned, is closed. However, ladies can always ring and ask for a screening appointment, and it doesn't matter. We would always open a screening slot up for them and see them. If we could have the next slide, Zara, thank you. With those interventions, up till now, our uptake has been here. It's been between 56 and 74%, and we've gone down the CCG. So this is what our current pre-COVID state of play is, with the health promotions that we have currently, and that sequence of having 2 timed appointments at locations close to the client's home. If we could have the next slide. What's going to happen in sort of October onwards is that rather than having timed appointments, ladies who are due for screening or who are overdue for screening, since we paused the breast screening service on the 23rd of March, they will get a letter explaining to them that they are due for screening. They will have inside the envelope an information leaflet allowing them and giving them the risks and benefits of breast screening and allowing them to choose, and also a number to call the central admin hub. I just want to go to the next slide, but that's just a dummy letter that we have on the system to just show what the ladies will be getting. Our concerns are that that is a letter asking them to contact a central hub to make an appointment. And it's very different to the process that they had before. So that's for us the largest change between what was happening for the 28 years that the breast screening service has been running to now, when we've restarted and reinstigated screening. So if we could go to the next slide. We have evidence. We've already got peer review papers that tells us that this open invitation is not as good as timed appointments, and certainly not as good as 2 timed appointments. But the current, and I'll come on to why we're having to do this later in my talk. So we know that the new service has a risk of us having less ladies through the door. And the other thing, in order for us to be able to move along and offer screening to everybody who needs to in the short term, and I mean in the short term, such that we can recover our screening program back to where we should be in April of next year, means that we have to make some difficult choices and do some difficult things in the next 8 months or so. If we could go to the next slide. The next few slides are copies of a presentation written by Tavi Tillman, Sarah Robinson and Chris Williamson. So I'm absolutely going to say, give them the credit for this, because they're such important slides to show you as to why it's important we get this right. So in South East London, and particularly Southwark, we know that ladies in affluent areas are 14% more likely to be diagnosed with breast cancer. We think that that is related to a greater uptake to screening invitation, greater awareness and vigilance even, and also an ability and a willingness to access healthcare. If we could go to the next slide. We know in the more deprived areas, there's 16%, worryingly, a 16% lower survival rate when people have been diagnosed with breast cancer. And we know that 9% less is likely to be even diagnosed within in deprived areas. So we know that that probably is due to a lower uptake from screening programs. And I think that crosses all three screening programs that we're talking about this afternoon, but we know that this data relates to breast screening. If we could go to the next slide. From an ethnic diversity point of view, we know that Black women have 12% lower survival rates when they are diagnosed with breast cancer. We know that in London, we have lower screening attendances within the Black community. And in South East London, there is a very specific concern around Black African communities who are twice as less likely to attend screening than white and Black Caribbean communities within our services. Now, generally, there's always a statistically lower uptake rate within the ethnic minorities. And so we have this picture of lower uptake and poorer outcomes. If we could go to the next slide. So I think this is a really important slide. It shows us that 89% of breast cancers diagnosed by screening are within stage 1 and stage 2. The 5-year survival, if we pick it up that early, ranges from 88% to 99% 5-year survival. So if we get it early, it makes a difference. It makes a difference to their survival, it makes a difference to the level of treatment they need, and it makes a difference to them as well as us as both primary and secondary carers for this community. So I think it's really important that we know that. And if we look in red, I've got faces of the panelists covering this up, but I'm hoping you're seeing the whole screen, is that we're, by screening, we're picking up 3 times as many breast cancers as those that we pick up by primary care referring to the 2-week wait pathway. So I hope that those last slides, which were really excellent slides from the JSNA from Southwark, have shown why screening is important, why it makes a difference, and how it genuinely makes a difference to the ladies to be picked up early, and also to us as carers of the amount of input that we'll need to do, because the stakes and the treatments are so much less than when we pick them up at stage 3 and particularly stage 4. If we could go on to the next slide, please. So as we sit here today, we've got a backlog in London of 110,000 ladies in that 23rd of March to today. And there's an estimated 500 breast cancers in that cohort. For South East London, we think it's about 25,000. And as we heard in the last talk, the capacity is constrained now by workforce, social distancing, and PPE and infection control. To be able to screen the ladies that should be screened in September 2020, plus those who are waiting in the backlog from March, we need to give the service 140% of the capacity. But we know that the screening appointments are longer for those IPC reasons. So we're trying to work clever, we're trying to work differently to get up to at least 100%, which at South East London we have a plan where we do, and slightly more. So we're going to increase the way we work. We're going to use a very precious commodity of radiographic workforce and use them in a way where we protect them not only safety from COVID, but also RSI, which is the other thing that one needs to know when you're taking many mammograms of ladies in awkward positions all day, every day. We at King's restarted our screening programme on the 10th of August, and we are building up and bringing on new sites weekly to 10 days, and hope to be up with a proviso that the admin hub can support our plan with invitations, and NHSI will support the plans and how we want to work differently going forward. But our aim is to catch up by April 2021. If we could go to the next slide. Now, if we don't catch up, if we don't do things differently, what will happen is that the round length, that's the ability for the service to call all of our ladies for their 3 yearly mammogram within 36 months, will run long. So if we're calling ladies at 38, 39, i.e. over 3 years, that the delay is there, and then there's also a delay in diagnosis involved. And we can't get to a stage where ladies are presenting to the symptomatic service more than they're being picked up at a later stage and having more treatment. So this is a national problem. This is clearly more acute in London, where we've got a more diverse and more of a population. But as a national mitigation, they have made some changes which have come up from high, and we are going to do, for the reasons is the quicker we catch up, the less we disadvantage the whole screening population on that 3 years. So in South East London, we have 253,000 ladies who are eligible for breast screening that we need to get to try and save, to try and ensure the safety of the service and the ability to offer all of those ladies in the future. We've had to do some difficult things, and that's partly what I'd like to bring out in the talk. So going forward, there will not be any more timed appointments. So that first slide where we went through first timed appointments and second timed appointments, that will no longer be the case. They will get that open invitation letter, which encourages them to ring the hub and make an appointment to come for screening. It means that we use the screening slots the most efficient ways, because if ladies ring, they're going to turn up. And therefore, if we're putting on the clinics, we're screening as many women who actually want to be screened. The self-referral for ladies over 71. So ladies, once they've had their final screen before their 71st birthday, are often given a little card to say, we really want to continue screening you, but you won't get an automatic invitation because that's the system. So in 3 years' time, please ring this number and we will make an appointment for you to have some more screening. And the process is exactly the same. For a short interval, we're not going to be doing that. So you may, in primary care, see 71-year-olds or above coming to you with concerns. And for the short time, we need to use the symptomatic service for that small cohort of ladies. So we're not talking about every 71-year-old. It's the 71-year-olds who are due to come back for screening within this March to April time. It's that had a screen 3 years ago and they were under 71. The other thing is the age extension trial has been ceased. Actually, it's been stopped. So we won't have to invite those. All of those things will mean that the capacity that we are able to offer will more suit the ability for us to screen the ladies who want to come and get through that backlog quicker. If we could go to the next slide. So what's our ask of you? And it really is very similar to the previous talk. We really want you to champion the breast screening. When they get that letter, you know, we really want you to encourage them to phone that number and to tell them it's different. Don't not wait for an invitation to arrive, but this time around you've got to ring and then they'll give you the appointment. And we want every health contact everywhere we can in South East London to involve this as a conversation in anyone over the sort of age of 49, and to say that if you get a letter, if you receive this letter, please do book an appointment and try and make every one of those health contacts convert into an appointment for breast screening for us, because we really need to. We know, and we're all worried, and I'm sure everyone in this audience will see the risks of this, is we need to get to those communities or hard to reach groups within the whole patch, so that we can do some focused interventions to try and get areas to uptake the offer of screening. And we would really welcome help from anyone in the community for us to do, and we'll send comms out as to how you can contact us, or use my email address, so that we can start to target our own communities, as I think that intelligence is absolutely within the practices, and we'd appreciate your help in that. And then the last thing you can do is just to be aware of the over 70s, and to understand that if there's any symptomatic concern, if a 71-year-old or above comes with any kind of concern, to refer them quickly to the 2-week service. And when we return to normal business as usual, we'll communicate that back out again. If we could have the next slide. The next 3 slides is just a way of us sort of communicating to everyone in all the 6 CCGs when we are planning to start screening your areas. So we've done an assumption, because we would like to start screening the last lot of ladies, which are the ones we should be screening right now, plus a bit of backlog. From the 1st of October. If we're given the October go ahead by Central, then these are the practices going through each of our CCGs. So this is Bexley and Greenwich, and we'll be screening October, November. For Lambeth and Southwark, it'll be going through from October through to December, and we've put the postcodes that we'll be calling. Lewisham, you don't need to take these down, because of course they'll be shared, but for Lewisham, again, it's between October and December, and then we'll put that through to the next. And lastly, Bromley, who have the highest uptake for our footprint, will be calling through a little bit later than that. So that's the end of the talk, and I hope I've just sort of given you and highlighted some of the changes, and I welcome any questions, because I think that might be more helpful. Zara, I think you might be on mute.
Sorry, that was just me talking to myself. I've just brought up some questions. Keshthra, can you see them?
No, where am I going to look at them? The appliance, appliance and me. Am I going to Q&A?
Yeah, you are. That's
okay,
right.
Fine. So what happens to more vulnerable patients with booking appointments either by phone or email? So when patients want to ring the hub, they will be offered appointments wherever. So we have got, I suppose it depends on what you mean by vulnerable. We've taken delivery of 2 vans, and we'll take delivery of 2 more before April, which all have mobility access. So we will now be able to offer access in more widespread towards a whole access. Before, we had only 2 static sites that we could do that, and that was Queen Mary's Hospital and Denmark Hill. Now we can offer a little bit more. So Miriam, if you want to tell me what you meant by vulnerable, then I can answer that maybe a little bit more specifically. Can you please send the central breast admin number out in practices? Yes, we're doing some comms, and we're doing comms in form of emails, leaflets and posters. And in fact, we had a meeting just this morning, and what we've done is put some comms out and had some feedback, because one of the things is what we want is it to be fit for purpose. So we've taken advice, and we've taken feedback from colleagues on this call, and also we want to show it to patients, and that will then inform us on that, and then we'll send it straight out. But that's exactly right, Emma, that's where we need it to be, and we'll give you contact for both us in the service as well as the admin hub, because what we also want to know is if there's any issues around clients getting appointments, we need to know about it so that we can escalate early, and we can then follow up to individual levels and make sure they get. So language barrier, thank you. Miriam said language barrier, disability, learning disability. So disability, we already have a process, and we identify them, and we're giving appointments appropriate to their needs. Language barrier for us is an absolute must, because we do know that there are pockets. So one of the things we're doing as part of the comms is being able to do a plan where the leaflet, the help you choose leaflet, and the letter goes out in as well as English in the language that they want. There's a link and a website that they can go to. And the other thing we can do then, if we know that there are local practices that want us to provide that, or feel that we need to reach out to community leaders, then we will, because that's, I think, where we want to really target and get a lot back. Learning disabilities is a big it has always been something that we've worked quite hard about, and there is no easy answer. We've done a lot of learning as part of the CCGs, and we've done some work with One Bromley when we've gone through clients who may have got breast cancer with learning difficulties. So what we do is we need to know, and then we contact the client and plus or minus carers. We often have the ability to bring them to a site, familiarize them, explain what's going through before the event, and then bring them back and do mammograms. And interestingly, sometimes when they come, they just go ahead and have the mammogram done. Other times they want to come back having been walked around and we always try and make sure they all know that this is a female only service as far as the screening, the primary screening area is. So it remains a challenge. It would be disingenuous of me to say it's all completely fine, but we are working hard, and we are aware of that.
Thank you, Keshthra. Thank you, Emma. What we'll do is we'll take that offline. Your point about recalling patches and knowing when invitations are being sent out locally. So we'll take that offline. So thank you for that. And now on to our next presentation, which is with Nicola. Let me just, and she's going to be talking about cervical screening. So Nicola, over to you.
Hi, I'm Nicola Weaver. I'm at Macmillan GP in Southwark. Here we go. So prevention and early identification of cervical cancer is a major public health priority, because we're still having 9 new cases of cervical cancer every day, and 2 women are dying of it. And the thing about cervical cancer is it's so very treatable if it's caught early. So 99.1 people survive if it's picked up at stage 1, compared to only 35% at stage 4. So next slide. The target population, and you may all be familiar with this, I'm just going to go through 2 or 3 slides for anybody who isn't. The target population is for women between the age of 25 and 65, and for anybody with a cervix. And there is a point here that the programme of call and recall is based on GP registers, and if a trans man is on a register but still has a cervix, he won't be picked up through the screening programme. You would have to, as a GP, contact the centre and arrange to have the sample dealt with, and then deal with any abnormality by making a referral yourself. So women start screening at 25. They're screened 3 yearly between 25 and 49, and then 5 yearly after that. The last screening is at 65, unless you've had an abnormal, in which case you'd have another one. Next slide. So people are probably familiar with the fact that the HPV test now takes, is the first act with the sample, so that further actions depend on whether that's positive or negative. I'm not going to go through this table in detail. We will share the slides, and if you haven't quite taken in what the process is now, it's a CRUK slide, and it's very easy to read, I think. So just going on to how the process works and how it's changed recently with COVID. What normally happens is that a list of individuals who are due to be screened is sent to GP practices, which allows them to look and remove the names of anybody who's decided they don't want screening. And then after 4 weeks, the people that, at that point, anybody that hasn't been notified as being withdrawn has an invitation letter sent to them. At any time, you can do a sample on an opportunistic sample on someone who has been a non-responder in the past, but you can't do a sample on somebody who is not yet due for the next smear. Opportunistic screening is not appropriate for anybody who presents with symptoms. That should be sent through the gynecological pathway. So don't take smears if they're not due. Deal with the clinical situation. Next slide there. So what happened with COVID? Well, sample taking in primary care stopped on the 31st of March, and invitations were paused from the 10th of April for 8 weeks. They have now resumed, so from the 6th of June, invitations recommenced. The time periods between the practice prior notification lists and letters going out is slightly longer, so invitations have been issued on lists that were looked at 12 weeks ago rather than 4, and reminder letters will also be delayed to 30 weeks. Next slide. Oops, sorry. So all women are now receiving their normal invitation letters, and we know that at least 86% of practices in South East London are sending samples. The figure might actually be higher because some practices have closed, and that hasn't necessarily been reflected in the figures. Colposcopy services are getting themselves back into action, and things are moving through, and regular communications are being sent to primary care about the changes. Next slide. So there are, in the most recent letter, there is a cohort of people who received reminder letters to book for a smear just as COVID started, who will not be sent any more communication. And as practices, we are being asked to look out for these people who got the letter but then were not able to book for a smear. Because if they don't, they will come up in the non-responder list, and we need to make them aware that they can now book and have their smear done. The other group that we need to look out for is women who were due their last screening in that cohort just before COVID, because they also will not get another letter, and unless we identify them, they might miss out on that last smear. Next slide. So there's just a couple of slides in the pack just with some really useful resources about how to look at how the whole system works and answers questions that you might have around the scheme. And then in the next slide also here, this is a list of contact numbers which has in fact been supplied to all practices, but I know when things are sent to practices, often I don't see what comes to our practice because it's gone to somebody who deals with it, and so it might be useful to have this. So I'm going to go on now and just give a little bit, share some information about some work that was done in Southwark last year, also by a combination of the Public Health Department, the Cancer Alliance, and the two Southwark federations, IHL and QHS, looking at what was leading to inequalities in uptake, and there's some very interesting findings, I think, so I'll just go through those quickly with you. So we know that the uptake across South East London of smears, which we haven't got a slide of, but the overall the uptake is 69.6% at January 2020 compared to 72% in England, but there's quite a lot of variety across boroughs. So Southwark has an uptake of 66%. And what we also know is that everywhere the uptake of smears has been gradually falling, and it's been falling more in the 25 to 49 age group than it has in the older age group. So this means in London, because of the gradual decline, nearly 40% of young women in London are not attending for screening. And this is the age with the highest incidence of cancer, so it's really important. Next slide. The work that was done involved looking at all 45 practices in Southwark to look at information about the nitty-gritty detail of how they ran their processes, the smear taker capacity, and the training that was supplied. So the information was collated and collected, and it was then examined and considered by Public Health. Next slide, please. So all 45 practices confirmed that smear takers were up to date with training, so that didn't seem to be an issue. 3 practices confirmed they don't act on the prior notification list. They don't actually take out any names because they didn't have enough staff capacity to do that. All practices relied on national recall, but many also have some form of opportunistic follow-up themselves. Next slide. Coverage across Southwark practices ranged from 53 to 79%, and there was similar spread in both federations, north and south. Individual practice eligible populations also varied quite a lot. So you could have, there was between 23% and 36% of the population who needed a smear in any one practice. And what was found was that smear taking capacity wasn't really consistently matched to the population need across practices. The matching of capacity against population has been addressed in Southwark because the extended primary care services that now the PCNs are operating are offering a lot more out of hours appointments and weekends and evenings that nurses they've got nurses doing on behalf of the whole population, so that helps to solve that problem. It also helps to deal with the fact that people who are working might have difficulty accessing appointments. Let me see. Yes, so next slide, please. Oops, wrong computer. So I'm just going to show you a few slides that come from the public health analysis of the information that was gathered. And here we have confirmation of the difference in uptake between different age groups. So the 25 to 29%, 25 to 29-year-old age group were 57% are having smears, compared to 77% in the 50 to 54 age group, who are actually less at risk of actually having cancer. Next slide. This I think is a very interesting breakdown of the ethnicity of uptake. And it's quite hard to read because there's so many different lines on it, but basically white, British, Caribbean black and African black women have quite a high uptake at 74, 72%, but the groups that have a much lower uptake are the Asian, Pakistani, Indian Asian, Chinese Asian, so they're all down sort of below 60%. And I think that isn't something that I would have assumed without having seen this information. So if you go down to the next slide, this just spells out in a bit more detail that information about the ethnic differences, but also points out a point that was raised by the practitioners themselves, that language is a big issue, as always. So in the English-speaking population, 70% was screened, but with the non-English, it was only 59%. And we'll go down to the next. Sorry, I've moved. There were a few other factors pulled out which were quite interesting. Deprivation wasn't strongly linked to the results, but I think very much they felt that it was difficult to measure deprivation from the information they were able to gather, so that wasn't a finding that was of any consequence. But people who were underweight reported the lowest screening level of uptake, and the reasons for that were not clear to us. You can hypothesize about what it might be, but it was a very distinct finding in the study. And the other thing was that current smokers are less likely to attend for their smearing, for their cervical smears, something that we could take note of and possibly act on. Next slide. Oh, you've got it, thanks. Again, coming back to the disadvantaged vulnerable groups, learning disability has very poor uptake, with 39% being screened. And again, as was discussed by Keshthra, it's a very difficult area to tackle, but we do have a lot of information about the fact that people with learning disabilities and physical disabilities die a lot of years younger than their peers. And that, it really is an area that we ought to be trying to focus on. The other interesting point here is the HIV. Ladies with HIV should be having a smear every year. And although 78% of them had a smear in the last 3 years, only 35% had had one in the last year. when you send a smear on somebody with HIV, you have to write clearly on the form that that's why you're doing it, because otherwise it'll be treated as an early smear and not processed. So moving to the next slide, just some general comments that were the outcome of discussions about the work that had been done, was that, as you can see from the slides, eligible populations differ from practice to practice, and models need to be adjusted to reflect who you're looking after. Coverage of different groups differs, so focus on recall might need to be different. The old QOF masked the fact that we were getting lots of older women in, but not the younger women. And that's definitely an area to focus on in the future. There's the other obvious things about collecting screening history on registrations. There's one point which comes up often when I have these discussions. Women who have their smears abroad, some practices appear to have low levels because a lot of their population come from originally from overseas and choose to go away to have their smears and regular health checks, and that you cannot file that information into the screening record. So sometimes that will lead to a lower level of coverage. Next slide. So just to complete the talk, really, these are some of the things that make it, that stop people going for smears, and these are very well established in sort of the whole country over a long period of time, and they're all things that we can think about when we're trying to improve the system. And for the very last slide, we have just some of the ideas and initiatives that can be used to try and improve things. So the London Text Reminder project started and then stopped last year, but has been reintroduced. And during the period it was running, they did show a 5% uptake in uptake of smears. So it is actually very effective. We've had work with Joe's Cervical Trust going on with various practices, trying to identify and help to reach harder to reach populations. The federations in Southwark are putting on the extra out of hours appointments, which is making easier for people to get to appointments. And hopefully then long-term vaccination programs will make most of this not needed, but that's not coming yet. So we'll all have to do something about it before then. Okay, thank you. Sorry, the whistle stop, but we're running out of time, so I went fast. You're on mute, Zara.
Hi, hopefully everyone can hear me. Thank you for that. I just open up to attendees whether anyone has any questions. No open questions at the moment. I think if anyone has any questions going forward, because I know that we're running out of time, please send them. There is the generic email address that was on the flyer, but I can circulate that to everyone. If you have any questions that you think of off of the webinar that you want to ask any of our panelists, then please send those in, and then we can answer them, and we can put them in the document that will circulate afterwards with the slides. But if there isn't anything else, I'd just like to say thank you to the panelists. Thank you for your wonderful presentations. It's been a great hour. I hope everyone's got lots out of it, and looking forward to the next one. So thank you very much.